So welcome to OvarLive. My name is Runsi Sen and I'm the founder and president of Overcome. And today is World Pancreatic Cancer Day. And I'm joined by Dr. Anirban Maitra. We are going to sit and talk about ovarian cancer, pancreatic cancer, and its possible link with ovarian cancer. So just as an introduction, Dr. Maitra is the professor of pathology, deputy division head for academic science, as well as the scientific director for the pancreatic cancer research at MD Anderson Cancer Center. He's also the leader of the pancreatic cancer interception dream team, recently announced by Stand Up to Cancer and Lustgarten Foundation. So congratulations.
Thank you.
And finally, last but not the least, he's also our advisory board member. So thank you for joining us today.
Of course. Thank you, Runsi. And I should say this is World Pancreatic Cancer Day. So Runsi has kept her bit of the bargain by wearing purple. And she was kind enough to lend me a teal band. So I'm doing my bit for ovarian cancer. So I think
so there you go.
This is our looking out for each other.
Thank you.
Of course.
So I'll delve right in. So
Sure.
my first question. Mutations in BRCA1 and 2 is mostly linked with breast and ovarian cancers, but it's now gaining a wider recognition
Yes.
with pancreatic cancer as well.
Yes.
So can you tell us a little more about this and about any implications
Of course.
that the ovarian cancer community should be aware of?
Yeah, so as you know, the reason these genes are called BRCA is because of the link to breast and ovarian cancer. And we have now known for the last, I would say, few decades, although this has not become widespread till only the last few years, that there are other cancers besides breast and ovarian that can be caused by germline abnormalities in these two genes, including pancreatic cancer, as well as in men, certain variants of prostate cancer. So in terms of pancreatic cancer, there are families with germline alterations or abnormalities in the gene BRCA2 in particular that can lead to a higher risk of pancreatic cancer in those families. BRCA1 is less commonly associated with pancreatic cancer, but it certainly is also a risk factor for familial disease in these cohorts. So if you are from a family that has germline abnormalities in BRCA1 or BRCA2, and there is a family history of breast and ovarian cancer in the family, another thing to look out for and to screen for would be pancreatic cancer. And many primary care physicians don't know about this link. You think of BRCA and you immediately think of breast and ovarian, but the risk for pancreatic cancer, especially in the BRCA2 families, is something that we need to be more aware of, and certainly in most academic centers, genetic counselors are very aware of that, and so if they know that there is a family history of BRCA, they will also advise for screening for pancreatic cancer in those family members.
Wow, that's a great answer. This question is coming to you directly from a survivor herself.
Okay.
So she wants to know the possible link between ovarian cancer, pancreatic cancer, and Lynch syndrome. So her question is that how high is the risk to get pancreatic cancer if you have already had ovarian cancer and have Lynch syndrome?
Okay, very good. So we just talked about BRCA as what I would call one of the major causes of familial breast and ovarian cancer, but those are not the only genes. They are by far the most common genes. About 60 to 70% are caused by BRCA2 mutations, but there are other genes such as the Lynch syndrome patients that are also associated with an inherited predisposition to breast ovarian cancer. So for those of you who don't know what Lynch syndrome is, this is a disease where you have abnormalities in genes that are responsible for repairing damaged DNA. So if you don't repair your damaged DNA, you have a higher propensity to get certain cancers. In Lynch syndrome, the most common cancer that you get is colon cancer, but you can also get, especially in women, or rather exclusively in women, endometrial cancers and also ovarian cancer. The risk for ovarian cancer in Lynch syndrome is less than colon and endometrium. It's about a 10% or so will have a lifetime risk of ovarian cancer, but certainly it exists. Now, the risk for pancreatic cancer is significantly less than ovarian. Only about 1% or so of patients will actually have a pancreatic cancer history in the family. And so it's not something typically that we screen for in Lynch syndrome families, unless there happens to be other family members who have a pancreatic cancer history, or there is something additionally that might predispose, like other diseases of the pancreas, that might cause screening for pancreatic cancer to happen. But typically, the sites that we are more worried about are obviously the colon and the female GYN tract, the endometrium. And so why are we concerned about Lynch syndrome and the importance of knowing that particularly a pancreatic cancer that is Lynch syndrome associated has that abnormality? This is because this past year the FDA approved a therapy that is geared towards patients who have Lynch syndrome associated cancer. It's a form of immunotherapy, and it's actually agnostic to the organ. So you could have Lynch syndrome associated pancreatic cancer or Lynch syndrome associated endometrium or colon. This immunotherapy is used agnostic to the organ where the tumor occurs, and it's really decided more on, or rather exclusively on, the fact that it arose on a background of Lynch syndrome. So that's important to know. But in terms of the absolute risk for pancreatic cancer in Lynch families, it's really low.
Okay. Do we have any questions before we move along?
Questions?
Okay. So how common is it for ovarian cancer to spread into the pancreas? And in situations when ovarian cancer, ovarian tumors and pancreatic tumors are identified at the same time and the primary neoplasm is uncertain, what are usually the steps that you would take in terms of treatment plan for the patient?
Okay. So in general, ovarian cancer metastasizing to the pancreas or spreading to the pancreas is very rare. Overall, tumors spreading to the pancreas per se are very, very uncommon. In general, I would say the overwhelming majority of tumors that arise in the pancreas are primary pancreatic cancers. Occasionally, you will get tumors from the lung or the kidneys going to the pancreas, but ovarian cancer metastasizing or spreading to the pancreas is very, very rare. If we do see a situation where you have somebody who has both ovarian and pancreatic cancer, the first thing we would do would be a thorough pathologic evaluation to see, do they look like the same tumor? And if they do look like the same tumor and have similar genetic abnormalities in them, then we might consider that this is one of those rare cases of metastases from an ovarian primary to the pancreas. Now, pancreatic cancer and ovarian cancer have some distinct abnormalities or genetic abnormalities that define one or the other, so we can actually look for those. For example, there is one gene called DPC4 or SMAD4 that is lost in about 50% of pancreatic cancer, but is very uncommonly lost in ovarian cancer. So if we have a tumor that is both in the ovary and the pancreas, and it looks like it has lost this particular gene, SMAD4 or DPC4, then it is much more likely to be a pancreatic origin going to the ovary rather than the other way around. There are also other molecular tests that are now available, both in academic centers like MD Anderson as well as commercially, that can identify what we call the tissue of origin in cancers that have metastasized. And so these molecular panels can be done, and they'll help pinpoint, is the tumor coming from the pancreas to the ovary, or is it ovary to the pancreas, or are these, in the very, very, very rare situation, two separate primaries that are arising and just happening to present at the same time. Okay?
And so we know that both ovarian and pancreatic cancers have much in common, right, in terms of their being one of the most lethal cancers. They have, they do not have the advantage of early detection in majority of the cases, that is, and also there's a low survival, 5-year survival rate, right? So can you talk a little bit about these similarities in more detail and what our community needs to know in terms of pancreatic cancer awareness?
So I think that's a great question, and both of these tumors, they share certain unfortunate features. One, of course, being that the prognosis in general for both of them is not the best, certainly not where we would like it to be. Also, there is no easy early detection. I mean, there is no mammography or a pap smear or a colonoscopy you can do for either ovarian or for pancreatic cancer. In terms of the link, now we talked right in the beginning about the BRCA link. I think that's one very important thing to be aware of, especially for the unaffected family members. I mean, obviously, when you have somebody who's already got the cancer in the setting of a BRCA2 mutation, that person has the cancer, but then the siblings or the children of these patients now have an opportunity to what we call intercept the cancer. This is exactly what we actually were funded by the Stand Up to Cancer to do, which is to intercept the cancer in patients, or I would say asymptomatic individuals who don't have cancer but who are at risk for the disease. And so the first thing I would say is, if your ovarian or breast cancer is BRCA related, talk to your physician about the risk of pancreatic, and do you qualify or should you get screened for that. And this is especially true if you have a BRCA2 mutation associated ovarian cancer. That's something certainly to be aware of. The other things in terms of pancreatic that is not so much linked to the ovarian cancer incidence per se, but when we talk about just general awareness about risk factors for pancreatic cancer, I think obviously a family that has multiple family members with pancreatic cancer, these are families that should consider getting some sort of screening done. So at MD Anderson, we actually have funded through our MD Anderson Moonshot program a pancreatic cancer high-risk clinic. It's the Houston area's only high-risk clinic exclusively dedicated to pancreatic cancer families. And there is great information online on our Moonshot page if you want to look up how to get screened through this clinic. And this is meant for families where you have multiple family members with pancreatic cancer, whether you know what the mutation is that's causing the disease or not. Another risk factor that we have recently identified is the onset of new diabetes. So new onset diabetes in elderly patients, especially those 55 and above, is in a very small proportion of patients, about 1%, that could be because of an underlying pancreatic cancer. So I again want to emphasize, the vast majority of elderly individuals with new onset diabetes just have usual new onset diabetes. But about 1% of individuals, especially those where the diabetes doesn't seem to be responding to medications, or you lose weight and the diabetes is not getting better, there is at least the opportunity to consider that something else may be going on. And this is another situation where I think awareness is the key. Many primary care physicians are not aware about this link between new onset diabetes and pancreatic cancer, and so we're really trying to get the message out there through the primary care community, working with the American Diabetes Association, that this link exists. And if there are patients who look sort of a little bit atypical in terms of their response to diabetes medications and are not responding to weight loss, these are patients who at least should be considered for imaging studies for potentially harboring a pancreatic cancer. And then, of course, the usual things that you talk about, like, don't smoke, and, obviously pancreatic cancer is, like many other cancers, associated with a higher risk in smokers. It's not as much as lung cancer, but it's about twofold higher. I'm not aware what the risk factors for ovarian is in terms of smoking, but certainly we, as a blanket advice, I tell everyone, please, avoid smoking. There are way too many cancers whose risk is increased by exposure to tobacco, and you cannot go wrong by not smoking. And then there's also, like with many other cancers, there's a link between obesity or higher BMI and pancreatic cancer. And certainly it's not the only cancer that is associated with obesity. There is a great concern in the cancer prevention community that, given our current obesity epidemic in this country, we will see a lot more cancers that are associated with higher BMI. So maintaining a healthy weight and exercising, all the good stuff, obviously are things to be aware of.
And what about, I'm just curious, what about the alcohol consumption and pancreatic cancer?
So, there is a very low risk, or I won't say low, there's a small higher risk, mildly elevated high risk of having pancreatic cancer in patients who have long-standing what is called pancreatitis, which is inflammation of the pancreas. So if you have inflammation of the pancreas for a long period of time, so chronic pancreatitis, those patients have a mildly elevated risk of pancreatic cancer. And the most common cause of chronic pancreatitis in our country, in the United States, is in fact alcoholic pancreatitis. So if you use that link, yes, alcohol through chronic pancreatitis is associated with a mildly elevated risk. But just social drinking and all is fine.
Okay. So as we know, there has been this explosion of PARP inhibitors, right? At least in the case of ovarian cancer. So what we have also seen is there is a potential use of these PARP inhibitors for pancreatic cancer as well.
Of course.
So please tell us about the recent trial in pancreatic cancer as it is linked to BRCA mutations and also the PARP inhibitors.
Of course. So again, remember I talked about the fact that there are now therapies that are emerging and are getting approved by the FDA that are agnostic to the organ, but are driven really by the underlying molecular abnormality that's driving that cancer. A great example of that is the immunotherapy that was approved for Lynch syndrome. Doesn't matter what cancer it is, if it's a Lynch syndrome associated cancer, the FDA has approved a particular type of immunotherapy for it. It's kind of similar with PARP inhibitors. Tumors that arise in the backdrop of mutations in BRCA1, BRCA2, or other related genes, such as PALB2 is a third gene that's in the same sort of family. These tumors have a propensity to be more susceptible to PARP inhibitors. And in particular, I think Ronsi was talking about the recent approval of a drug called rucaparib from Clovis Oncology that was approved for ovarian cancers that have already received other lines of therapy, including platinum drugs, based on a trial that was done last year that showed that these patients have significantly greater duration of disease-free survival when they receive these PARP inhibitors in the setting of ovarian cancer that arises in the background of germline BRCA1 or 2 mutations. The similar findings have been seen in pancreatic. There was actually a study done called the RUCA-PANC study, which tested rucaparib in pancreatic cancer. And although there were some responses, including some patients who had really pretty stable disease for a long time, the number of positive responses did not reach the level that the company felt that they were going to push for approval. So especially given that these were patients who had already been through multiple lines of therapy. So Clovis decided that they were not going to pursue rucaparib in advanced pancreatic cancer that has received multiple lines of therapy, despite, as I said, occasional responses. What they're now doing is a trial that is open at the Vassar Center in UPenn and other places that is looking at rucaparib in BRCA1 or BRCA2 mutant pancreatic cancer, but in a much earlier setting. So these are patients who have received a little bit of platinum drugs, they're stable on platinum therapy, and then they're getting rucaparib in what we call the maintenance setting. Okay, there's another PARP inhibitor. There are, as Runsi said, there are multiple PARP inhibitors that are out there, either approved or being evaluated. The first one was actually called Lynparza from AstraZeneca, and Lynparza is similarly approved in the setting of BRCA mutant cancers. And so AstraZeneca is running another trial of Lynparza maintenance in BRCA mutant pancreatic cancer. It's called the POLO trial, and that's actually being run here at MD Anderson. The PI of that trial is right here at MD Anderson. And so that's for patients who are BRCA1 or 2 mutant, have received a little bit of platinum, they're stable on that disease, on that drug, and now they can switch to maintenance Lynparza. just like the maintenance rucaparib trial that's going on at the Vassar Center. So what is happening is that companies are not planning on using these drugs very late in the disease because they haven't seen much responses or benefits, but they're bringing the PARP inhibitors earlier in the disease process when patients have just received a little bit of platinum, they're stable, and what they're trying to do is to sort of really increase the progression-free survival or duration of disease-free survival in these patients as long as possible.
Well, thank you. Such great information. My last question.
Sure.
On this World Pancreatic Cancer Day, what is your message to our audience when it comes to pancreatic as well as ovarian cancer awareness?
Yeah, absolutely. I mean, I think the biggest challenge with these two lethal diseases is awareness. I mean, I think there is a reason why we have World Pancreatic Cancer Day, and November is Pancreatic Cancer Month, and you have your ovarian cancer awareness events. It's to really increase awareness, especially amongst patients, family members, the primary care community, because the problem with pancreatic cancer is the early symptoms tend to be very non-specific and are often missed, a little bit of back pain, a little bit of weight loss, loss of appetite.
Which is so similar to ovarian
absolutely,
cancer, right?
Absolutely. It doesn't mean that everyone with back pain should be rushing to get a CT scan done, please, otherwise we'll have an epidemic. But it's key to remember that when these symptoms start looking funnier than they should be, or are persistent, or they occur together in tandem, like you have persistent back pain that's not responding and you're losing weight, you should start, your physician, not you should never self-diagnose yourself, but your physician should be aware. And I would say that a lot of these awareness campaigns are really aimed more at the primary care community. Here at MD Anderson or at Hopkins or Sloan Kettering or Mayo Clinic, those typically are encounters that happen much later in the disease process. The diagnosis has already happened, you may have even received treatment, and then you come to these large centers. The gateway to early detection lies through our primary care physicians. They are the ones who need to know, okay, if you have BRCA2 running in the family, don't just concentrate on the ovary and the pancreas. Ovary and the breast. Think about the pancreas. In men, think about the prostate. Or, hey, there's somebody here with new onset diabetes who's not responding to metformin, who's not responding to weight loss. Could this person have something else going on? Maybe I should get an MRI on this person. These sort of, triggers really need to be out there in our primary care community. So I think for us, our goal of awareness is not just among the lay public, but also amongst the primary care docs who really form our gateway, I think, to early detection.
Wow, that's so much great information. Thank you
Sure.
so much, Dr. Maitra, and we appreciate you taking your
Absolutely,
time and
my
talking
pleasure.
to us about ovarian and pancreatic cancer all together.
Absolutely.
And do we have any questions? If not, we'll come back to our audience the next time. And thank you all for joining us.
Thank
and
you.
until next time, thank you.
Thank you.